The first session will be Obesity Management Update. May I request Chairperson for this session, Dr. Sathian Raghavan Sir, Consultant Endocrinologist, SKS Hospital, and Dr. Balaji Sir, Vascular Surgeon at SKS Hospital, to come to the dais. We request the chairpersons to introduce the speakers and moderate the session.
Good morning to all. Thanks Shanmuga Hospital team for the invitation. So today the first topic is obesity. As we all know, obesity is increasing in an unprecedented manner globally. It's like rising as an epidemic. The increasing BMI is an important risk factor for many non-communicable diseases like diabetes, cardiovascular disease, and some musculoskeletal disorders like osteoarthritis and all. So we have to control this epidemic. So in order to control this, we need a multidisciplinary team, right, ranging from endocrinologist, bariatric surgeon, and psychiatrist. So today we are having three speakers with regard to management of obesity. One is medical management, followed by surgical management, and what are the psychiatric diseases involved in some people with obesity. So first I would like to invite Dr. Sathian sir to discuss on medical management of obesity. So Dr. Sathian Raghavan did his undergraduation from Government Mohan Kumar Mangalam Medical College, Salem. Then he did his MRCP in UK, and he then followed by SE in endocrinology and diabetes in UK. Currently he is attached to Shanmuga Hospital and Pranit Clinic and SPM hospitals. He is a member of ESTN and Endocrine Society of India. He has achieved his special interest are thyroid disorders in pregnancy and diabetic foot. So I would like to invite Dr. Sathian sir to the stage to deliver the medical management of obesity.
Thank you very much, sir, for this kind introduction, and I thank Shanmuga Hospital for this opportunity, and I really welcome all the delegates have decided to spend their wonderful Sunday morning here. We hope you find this session useful. I will move on to my part of the topic. Can you have the presentation slide, please? Right. So, as it says, when it comes to obesity, we are evolving different models of management. One such is obviously, we know that it is not a single man's job. We really need a teamwork. So, as it says that pointer is not. Pointer is not working.
Seems there is a button on the side.
Yeah, it's switched off. Yeah. Okay, yeah. Can I ask you to change the slide, please, when I ask you to? Yeah, okay. I'll ask you to please change the slide when I ask you to, okay? So, as I said, do we really need an introduction? We know that the WHO estimates there's going to be more than 1 billion people who are going to be obese, and the projection is only increasing. The morbidity and mortality is also increasing, and obviously, why do we worry? Because The morbidity includes a lot: incidence of type 2 diabetes, cardiovascular disease, metabolic syndrome, chronic kidney disease, hyperlipidemia, hypertension, fatty liver disease, many types of cancer, sleep apnea, and the list goes on. So we have become so much desensitized to obesity. We see many patients, more than half of them are obese, but now we are at a point where we hardly even take notice of that. Next slide. So then brings the question, should we treat obesity or is it just we are making a hype of it? Is it just part of our lifestyle? But the evidence clearly show that yes, reducing weight helps. It leads to better blood pressure control, decreased incidence of type 2 diabetes, improves dyslipidemia, decreases insulin resistance, and decreases the pro-inflammatory markers and improves the endothelial function. So there is a definite and strong need for reducing weight. Next slide. So the way this talk has been designed is we are going to look at the challenges. Now this is not about in-depth academic discussion upon each. What are the practicalities? What are the current trends? What are the things we can offer to our patient as a multidisciplinary team? As an endocrinologic point of view, I am going to cover a few things. We already have many problems. One challenge is the media, which is a double-edged sword. It gives good information and bad information. The patients are not sure. They believe the media more than us. We see this every day in our day-to-day practice. Next slide. Next slide, please. It's not working. And then the myths about carbs and cals. We don't know where is carbohydrate, where is the fat, or which fat is good or which fat is bad. So as we can see, we have a large meal. Many of our patients coming to clinic saying that they have 3 meals of rice a day, and they say they don't take sugar in their coffee, so they think it's fine. So many myths we have to address. Next slide. And also about supplements. The internet and everything is full of supplements. They give a lot of false promises, unbelievable results. We try to believe them. So we are inundated with so much of information, we really don't know what to choose, what works, what is good for us. So these are the main challenges we come across. Next slide. And then most of our patients are in denial. We don't perceive obesity as a problem. We take it, it's okay. We don't realize the importance. Even if it is pointed out, we go into a form of denial. We try to believe that it doesn't exist, but it does exist. Next slide. And it's not easy. So whenever we want a solution to a complex problem, the first thing is recognizing and agreeing and understanding, yes, it's not easy. It is a problem. I need to spend time. I need to be realistic. I have to accept facts. Only then we can move on. Next slide. So we had tried so many things to fight with the endemic or epidemic of obesity, but we are not winning in many aspects. If you look at some of the traditional models, why they don't work? Because many models are incomplete. A patient who may be obese, who may wants to lose weight, if you are going to treat them separately and a specialist treats, and then for another aspect it goes to another place, some of the areas are not met. A patient may need a psychological assessment and help. If that is not met, if you just give them food advice and a couple of tablets, it may not work. So incomplete care. There is poor motivation for them. Is it rewarding? We know it's not. Asking a patient to lose weight, putting them to a regime, it's not very much rewarding. So that is the other issues. And then many situations it's not socially viable, economically viable, patients not affordable. And sometimes we give very unrealistic expectations. We have to be realistic. Many of the treatments are not evidence based. These are the issues. And then many treatments are anecdote based. So we hear so many times, I saw this particular person, he ate this first thing in the morning, he lost 20 kgs, so it will work. So we get a lot of anecdotes. And then we have this thing called yo-yo pattern or recidivism. That means patient tend to lose weight 5 kgs. In 2 months they are back to 5 or even 6 or 7. So they have this sort of effect. They drop weight, pick up weight. So there is no sustainability. These are the issues. Next slide. So that's where we think that we need a multidisciplinary management. That is how we can tackle obesity very likely in the future. All healthcare physicians should understand and agree that it is a teamwork. It involves lifestyle modification, diet, pharmacological, behavioral and surgical. The reason I highlighted pharmacological alone is maybe majority of that is done by the endocrinologist or the physician, but all the others. Sorry, can you go back to this? Please change when I ask to. So when you take all of this, all the team involved, they are involved in all our aspects. It is a teamwork. So you can't ascertain one role to one person alone. Next slide. And all treatment are going to be based on weighing the benefits and risks. All treatments have their own advantages, they have the disadvantages. So this needs a proper assessment, a frank conversation with the patient, looking at the benefits and risks. Next slide. And more importantly, choosing the right regimen for the right patient. That is again where it is important. A patient can have many reasons contributing to obesity, and there's no one size fits all. So we have to choose the right regime for the right patient. Next slide. So one important basic way to approach is recognizing the pattern of obesity, and it can be polygenic, the most common garden variety. It can be genetic or syndrome associated. It can be part of endocrinopathy, or it can be psychological, and again many more causes. So we need to try to sort of recognize, and most of the time it's more than one, a mixture of few things. Next slide. Couple of quick thing about diet. As I said, I'm not going to go in depth due to time restraint. I'm just going to quickly go through. Many patterns of diets have been tried. There's no end to the list. The common things we talk about: intermittent fasting. There is something called time restricted eating with calorie restriction. It has been tried. Some of them are effective in the short term. Some of them are not so effective in the long term. So we go more and more on evidences available. Next slide. Intermittent fasting, again at least there are 3 main times described, whether it's an alternate day fasting or 5:2 diet or time restricted eating. So these produce on their own a mild to moderate weight loss. And most studies are over short durations. And the question is whether this degree of the question is whether just reducing weight on its own, do they translate to better cardiometabolic risk profile? That is another big question. So if you are not going to achieve that, is there a point in losing weight? Next slide. And then we talk about very low calorie ketogenic diet, and it reports impressive weight losses up to 10 to 15 kgs in studies during the ketogenic phase. And then the question is, are we able to sustain it? Are we able to continue this lifelong? Whether this is going to, or we are going to fix a target and then we are going to revert back to normal. So all of this have a lot of questions, and this is exactly where we have to have a detailed assessment. Next slide. And exercise in weight loss, again the evidences are very variable. As I mentioned, a lot of anecdotes, short studies or individuals saying just with exercise I lost so much kilograms. But in reality, how much the weight lost with the exercise is very modest. On its own, exercise on its own is not going to make a person lose weight. In fact, any modality on its own is not going to achieve a great degree of weight loss. And again, the next question is, what about exercise time? Some say that though they do an intensive exercise, there are a lot of things which compensate for it. The remaining time you are sedentary, you match it up or catch up with extra calories. So end of the day, these confounding factors mitigate the actual weight lost. So this is something to bear in mind. Do we need aerobic or anaerobic? Again, multiple views. In general, a mix of both is the practical thing we can advise our patients. Next slide. So moving to my main area, pharmacological. I hope I'm not taking too much time. Now this is exactly where the next couple of decades are moving on. There are lots and lots molecules coming in the pipeline with regarding to weight management, especially obesity and related conditions. Now what we need to do is we should really focus on what are the things which are approved, what are the things which are affordable, what are the things which is available to us, and that is exactly what where especially any doctor who is encountering a patient with weight, they really need to have a realistic approach. Commonly we can put it, there are many categories, but common simple things are lipase inhibitors, centrally acting agents and incretin based therapies. Next slide. So the lipase inhibitors, we use orlistat. Now it basically reversibly inhibits gastric and pancreatic lipase and local lipase inhibition within gut. So the patient loses up to 30% of fat taken with meal. The practical advantage is it's an easily orally available thing. You just take it twice or thrice a day after meal and increase the dose according to respond. But when you look at some of the studies, the percentage of weight lost with orlistat, if you compare with placebo, is around 3%. But it does have its own disadvantages. Clearly tolerability issues, GI side effects are one of the important thing, and other issues regarding close monitoring of renal and hepatic function. And then it has a very narrow group where we can use safely. Many groups are excluded where we can use orlistat. So orlistat is effective to an extent. In a correctly chosen patient, we do use it. Next slide. Centrally acting agents, they are very, very conceptually good thing, because end of the day, it's your appetite, the areas the areas which are controlling your appetite. So if you are able to master your brain, will you be able to control your weight? So on this aspect, many drugs have come and gone, and those much more seniors like my professors all sitting here, you would have gone through different drugs which have come at different times, shown promise, and then they have been withdrawn due to multiple and serious adverse events. Yeah, I'm sure we know there is generation we came across like cardiac issues, pulmonary hypertension, etc. And at the moment, the phentermine topiramate and naltrexone bupropion are used, but almost all of the others have pretty much come out of the market for one or the other reason. Even the more recently promising lorcaserin, and that has been withdrawn a couple of years before, whereas there was concern with cancers. So again, this area, though it looks promising, in reality we have limited molecules. Next slide. And that's where a big ray of hope came, which is the incretin based therapies, and these are showing very encouraging and promising results. And initially, obviously, what happens is, the advantage is these days when we study about any one particular condition, now when we try to develop a molecule, that also teaches us more science and physiology about us. So that's how when we develop a molecule for diabetes, we accidentally or intentionally hit our other benefits, and then we spread the other benefits to other conditions. Likewise, when the role of incretin was mainly investigated with view of diabetes, it showed a big light on other things including metabolic syndrome, obesity, etc. So now we are developing more and more molecules for weight loss, for obesity, who doesn't necessarily need to have diabetes. That is one of the important take home, where diabetes has just become one of the criteria. We recognize obesity and other things are equally important. So more molecules are developed for those who don't have diabetes also. Next slide. So brief look, GLP-1, the appetite regulator, and again I don't want to go in detail. It has wide action everywhere. One of the important molecule which is very much involved with our satiety, intake, weight control, etc. So clearly it has a very positive effect in weight management. Next slide. So now I talked about the GLP-1 therapies. As I said, there are ones at the moment which are licensed mainly for those with diabetes, and now we are getting more and more molecules with indication for any patients with obesity beyond diabetes. That is an important thing. So we were limited with licensing issues that we may be able to use a GLP-1 log previously only in those with diabetes, but now things have changed. So this is one of the molecules, the semaglutide, and this has shown the step trials have very good significant, and the numbers we are seeing here are percentages, and there is a, compared to placebo, they have shown a significant weight reduction. Again, due to short of time, I am just giving an overview of what are the things we can offer our patients. We can discuss later if we have more time. Next slide. And then as we can see, that you even compare with liraglutide or orlistat, you can see the significant amount of weight loss achieved. Next slide. So at this moment, when we look at India, the approval status, as I mentioned, there are many molecules in the pipeline. So we have to keep up to date. When any new molecule comes, we will try to see whether it will fit our patient. At this moment, we can see what are the ones approved in India officially. And again, the most important thing is the one at the far end of the slide, which is these all have to be an adjunct to diet and physical activity. There is no alternate for that. Any agent is not going to work if you don't follow the basics. So diet, lifestyle, these have to be fully taken care of. Otherwise, any intervention won't work. Next slide. As I said, there are many more molecules waiting to come up in the near future, and again, the practicality, the availability, the cost are always going to be questioned. But anyway, it is important for us to be aware of this so that at the right moment for the right patient we are able to use them. Next slide. So incretin based, you have already, we have got, as I said, semaglutide, liraglutide group of thing, and then the newer things like tirzepatide is coming, showing a bigger promise, retatrutide, and the list goes on. All of them are showing very promising results. And of course, these are research settings, and some of them have actually proven in real world studies. Some of the GLP-1 logs have done so well. I'm sure you would have read about the molecule running out of stock in the markets in some Western countries. Next slide. So this is one where the tirzepatide shows even a better control than semaglutide. Again, I'm not going to go in detail. As I said, we just want to have a bird's eye view of what are the things we can offer. Next slide. So that brings us, as I said, as a successful multidisciplinary model, and this can be applicable to any chronic care. So there should be a long-term commitment. There should be an acknowledgement about individuals' lifestyle, what are the limitations, their behavior patterns, etc. It's very important. And it should be a patient-centered care. Pretty much the success depends on what the patient can actually do, not what we advise. So it is something we have to, the goal setting should be realistic. We should build the skill of the patient to do self-manage, because this is a chronic condition. We are not going to get an answer in a week admitting in a hospital. This involves a regular building rapport with our patients. And as I said, multidisciplinary team is the key. So the specialists between themselves, they should know each other very well. They should have a common understanding so that the goals are better achieved. And that's exactly the one of the core part of this talk, which is an on-site multidisciplinary management. If a patient needs a condition like weight management, there should be a team who know each other well, who know the patient very well between them, so who can share their ideas and then work out which modality is best for that particular patient. And then evidence-based and protocol-driven care. As I said, we don't want to give random things and say, okay, try this, try that. We want something which really works. and do it properly. Next slide. And important thing is this has to be individualized. I think we've discussed it already. There are so many patterns, so many reasons for obesity in each patient, so there is no single solution. Next slide. Again, at one site, as I mentioned. Next slide. So as the multidisciplinary includes primary and secondary care. It's just not the multidisciplinary team in the hospital. It's a team both involving primary and secondary care, because as mentioned in the initial note, you are the first line of contact for most of the patients. You are best positioned to identify those patients where weight could be an issue, where referring them to a further care will be beneficial for that patient, and this has to be a continuous and constant process. Next slide. So as I said, this is not a one-off step. It doesn't stop with referring a patient to us or any team. It is about primary and care regularly discussing about the patient. There are things which can be done in hospital, there are things which can be monitored by you. We can have a feedback. We can see which works better for which patient. And in the long run, I think that's how we can establish something which is going to be successful. Otherwise, it's going to be random and hit and miss. Next slide. So it's a long way to go, but we can. And one final thing is, which I have not intentionally mentioned, that the reason is, one of the other thing is the role of health tech companies who have come a long way, who can bridge the gap, help the primary and secondary care, help the patient, join them. They can follow them up in the community. I've not mentioned that because there is a talk being dedicated to that, how that is a newer thing emerging. It is in the post-lunch session, so I will leave it to them. At this point, I really thank you all for listening, and I'll just hand it back to the chairperson. Thank you. And this session, the discussions will be at the end of the talk.
Thank you,
Thank you,
sir, for
sir.
the wonderful speech.